Hey guys, welcome to rdhblueprint.ca. My name is David. Today we're discovering and learning all about orofacial anatomy. You should know this already, but we're going to go over the basics. I'm basically going to tell you what I think you should know for the RDH board exam in Canada so that you don't waste your time studying that's not going to be on there. I do not get into the veins or arteries of the face. Yeah, that could be on the exam. I just didn't think it was worth the gray hair. I didn't have a gray hair to give it, so I moved on. It could be on the board exam, so if you want to study that on your own, you can find that on your own textbooks, but I'm not going to be covering it in this series. Okay, get two devices. On one, you're watching this video. On the other, you're logged into my website and you've got the PDF there. You can scroll through slowly, make your own notes, pause the video as you need to catch up, look at the PDF, and then from this point forward, you study your own notes. Okay, let's chalk and talk. Orofacial anatomy. You should know we have 8 cranial bones, 14 facial bones. So that's 22 bones in the face combined, or 22 bones in the skull. So these are around your brain. These are in your face. You do have more bones than this because, of course, you have the inner bones of the ear. But if asked, we have 22 bones. Okay, 22 bones working together. 8 for the brain, 14 for the face. Know it. You should know this already. Here's a diagram. You probably have lots of these diagrams already in your textbook. I just have one here for you, but you should know this. Much more detailed than what I've got here. Your frontal bone, your parietal bones, your ethmoid. You don't need me to say all the names of them for you. You have it. You can go through this. Know the bones of the skull and face. You do not need to know the names of every suture, okay? Every landmark. You don't need to do that. It probably won't be on the board exam. I didn't memorize all that. But you need to know what a suture is. It's a joint where two things grow together, the bones. Fibrous joints that connect the skull bones, and eventually they unite together and be hard. Okay, they become very hard. Think of them as seams holding the protective helmet. By adulthood, they completely ossify and they're not flexible at all. Of course, the babies, it's still soft because they're still growing. But for an adult, it's really hard. Know which ones are paired and unpaired. That could be an exam question. I could see them asking something like, which of the following is not a paired bone? So your mandible, there's only one. The vomer, your frontal, your ethmoid, your sphenoid, your occipital, that's just one bone. But the paired bones, right, that's going to be your parietal, your temporal. These are all going to be like 2 of them, right? Your zygomatic bones, know that. Cranial bones protecting the brain. And I'm just going to highlight one thing for you. The sphenoid bone, that's a butterfly shaped. It's the one that touches every other cranial bone. It's the sphenoid. That's what it looks like. So you have the greater and lesser wings of it, right? Outside the orbits of the eye. You have the pterygoid plates. This is attachment points for the pterygoid muscles. And the sella turcica, the Turkish saddle. This is where for the pituitary gland, it sits in there, right? There's a little gland sitting on the saddle. So a memory tool is old people from Texas eat spiders. Occipital, parietal, frontal, temporal, ethmoid, sphenoid. That's what you can remember that. Let's talk about foramen or foramina. These are windows. Think of foramen as just a window. One is foramen, 2 of them is foramina. The windows that blood vessels and nerves and other structures can go through. Main one, we have the infraorbital foramen right below our eye, and I recommend you do orofacial alongside radiography. Do these classes back to back because they may ask you what is that radiolucency below the orbit of the eye in a radiograph, and they expect you to know, oh, that's the infraorbital foramen. That's the below the orbit hole. They want you to know that. So if you just memorize the bones, it may feel like kind of random, but as soon as you put that with the radiograph, okay, what's translucent, what's radiopaque, then you're going to be able to put 2 and 2 together. So the infraorbital foramen contains, or is a window for the maxillary nerve 5, division 2 to go through. It's the landmark for the infraorbital nerve blocks to anesthetize the upper lip, side of the nose, and the lower of the eyelid. And it gets you the ASA and MSA to combined. The mental foramen, which is down here by your premolars on the mandible, It transmits cranial nerve 5-3. It's a landmark to anesthetize the lower lip, the chin, basically half your mouth at the bottom, except for the buccal block. Mental foramen is useful and visible on periapical radiographs of the premolar area, so don't think it's an abscess or a cyst. So for the mental foramen, don't confuse it for a cyst. Don't mistake it for periodontal pathology. It's not. So it's near the medial or inner surface of the mandible. Nerve and vessel entry, importance for the nerve block, right? For the inferior alveolar nerve block. The incisive foramen, which is the nasopalatine, like right here. That one, it's going to be for the palate. Right, transmits nerve from the cranial nerve 5, division 2. It's a target for nasopalatine nerve blocks. Now, it's uncomfortable, not because of the nerve, because the tissue is so tight here, there's no room for the anesthesia to go. So it feels like it's crushing all the little cells there as it expands into the tissue. The greater palatine foramen, or the GP, it's on the posterolateral of the hard palate, typically near the junction of the maxillary second and third molar, way back there. It transmits the greater palatine nerve. Isn't that neat? The greater palatine foramen transmits the greater palatine nerve. Makes sense. It's the landmark for the GP nerve blocks. Great. Foramen ovale. Think of this for your mandible. What does the cranial nerve 5, division 3 go through? Think, oh man, I knew that. Ovale. That's how you're going to remember this. It's on the greater wing of the sphenoid bone, the base of the skull. It transmits cranial nerve 5, division 3. It's the largest branch of the trigeminal nerve, the 3-twin nerve. Memory nerve sounds like, oh man, for the mandible nerve. Foramen rotundum. It's in the greater wing of the sphenoid bone. Its rotundum means round, like round. It's the superior foramen ovale. So cranial nerve 5-2 goes through this. So 5-3 is oh man for ovale, but 5-2 goes through rotundum. And that's for your PSA, MSA, and ASA. If you haven't done local anesthesia, I suggest you do this after this course. Okay, know your LA, radiography, and orofacial anatomy. They kind of all dovetail together. That's why I'm telling you, don't do this class till you're getting, 95%. If you're getting 80%, move on to the other ones because a lot of the information will reinforce itself. Stylomastoid foramen, supraorbital foramen, jugular foramen, these are less important, right? But the stylomastoid is for cranial nerve 7, right? For your mastoid process here, can cause facial paralysis. On the superior orbital margin, the supraorbital foramen is branch of 1, right? For cranial nerve 5 versus branch 1. Your jugular foramen between your temporal bones and occipital bones back there, it's for cranial nerve 9, 10, and 11. And it's involved in the gag reflex. Your nerves through there. Now, in more detail, let's go over the temporal mandibular joint, where the temporal bone and the mandibular bone meet together and form a little joint there for our jaw. Let's talk about your temporal-mandibular joint and the two movements it has. It has a hinge movement and a sliding movement. First, we have the hinge movement. When you start to open your mouth, you'll see. First, your jaw just drops, and then it starts to slide forward. So the hinge happens first, then it slides forward. To open wider, the condyle must slide forward along the articular eminence in the upper compartment, and this gliding motion occurs. This makes it a gangliomyothyroidal joint, or however you pronounce that. I have no idea. But it's classified as a synovial joint, meaning it has a fluid-filled cavity that allows free movement. So the TMJ is made of the mandibular condyle, the mandibular or glenoid fossa, an articulating disc, an articulating eminence, and the joint capsule. Let's look at this together. Here is your little fossa, or little bowl. This is what it's sitting in, your glenoid fossa, your mandibular fossa. You have your condyle of the mandible. You have a little disc in there that articulates or joins the two things together. And you have articular eminence. This stops it from going too far forward, right? Glenoid fossa. So the lower compartment is the space between the mandibular condyle and the inferior surface of the articulating disc, because the articulating disc has two surfaces. There's an upper and lower compartment. This disc actually has a little hollow part in the middle, so it can move freely. Okay. The lower compartment's involved in rotation. The upper part is with translation, meaning moving forward. So the space between the superior surface of the articulating disc and the temporomandibular fossa and eminence, this is where the sliding occurs. So the articulating disc moves with the condyle as it slides forward in a healthy TMJ. The disc stays positioned between the bones throughout all movements, providing cushioning and smooth function. Okay, so draw this out. Know you have an upper and lower compartment of that disc, and that the upper one is involved with gliding and the lower one is involved with rotation. And that rotation happens before gliding. Muscles that move the mandible. This one you should know in more detail. Okay? They're your main muscles of mastication. Your elevation, depression, protrusion, retrusion, lateral intrusion, side to side. Know what muscles do it. Write this out. You don't need me to read all these to you. Right? Which ones close the mouth, which ones open, which move it side to side. Write out this chart and know it. Innervation of blood supply. Innervation is coming from cranial nerve 5-3 for all muscles of mastication, and blood supply is coming from the maxillary artery. I didn't go into all the arteries and veins of the face. I thought it was too much to know. If you want to learn it, you can. Took my risk. I took my chances. I wouldn't be on the board exam, and I couldn't be bothered to learn it. And there's a superficial temporal artery that helps supply blood as well to the TMJ. Temporomandibular disorders, sometimes it's been called TMJ disorders, or I have TMJ. That's just saying I have a temporomandibular joint. Well, it's not that helpful to say I have a TMJ. You have a TMD, temporomandibular disorder. These are problems now with the TMJ. That's what you're saying. So you could have pain. Clicking or popping sounds in the TMJ indicates a disc displacement. A limited opening, so trismus, you're locking your jaw fully open or fully closed. Or deviation, the jaw shifts to one side or another during opening or closing. Common causes of this can be bruxism, grinding the teeth, stress or trauma, arthritis, malocclusion, so the teeth don't fit right together. So you keep grinding your jaw, trying to get the teeth to fit in the proper grooves. Let's go over tooth eruption. What time do teeth erupt? We've been over this before in radiography, but we're going to go over it again here. The way I remember it is Anni. If you remember that, or Annie. I do. 1, 2, 3, 4. Kind of looks like an A. Okay. Then we're going all the way over here. And you draw that. That's how I draw it. So what does this look like, really? If these are the teeth here, the central, lateral, canine, first molar, second molar, I remember it like this. The mandibular central incisors first, then the maxillary, then the lateral, then back down to the mandible. Then here we have something that looks like an N, don't we? Straighten at the first molar at 13 months. Then at basically 2 years, we have our last molars come in. So that's how I remember it. I would write this out right before the board exam to help me remember. As soon as the board exam starts, I write this out anywhere I can just so I have the eruption dates there. Because you get a lot of questions saying, how old is this person? And you're expected to know based on that, looking at a picture, oh, look at the teeth erupting there. I think they're this old. Permanent dentition, the way I remember that is the word main. So here, now we're going to start with your 6-year-old molars. That comes first. That's our eye. Then I'm back here to my central incisors, starting at the mandible. You can see it looks like an M, doesn't it? Up, down, up, down. Then I go across, like that, and then back up to the upper canine there. Gives us our little A. And then we have an N. We're starting now with our 12-year-old molars, like that. That's how I draw it out. That's how I remember which one comes first. This is something you can easily do. Write it out yourself. Do it the week before the board exam. It's fast to memorize, and you'll probably forget it and learn it. Forget it and learn it. But you can do it even the morning of, right? Just practice writing out your eruption dates. Okay? Expect to know this for the board exam. Cranial nerves, your neural network from your brain to the rest of your body. You do need to know these cranial nerves. You should know what they innervate, if they're sensory or motor. Do they just feel things or do they actually move muscles? So we have olfactory, optic, oculomotor, trochlear, trigeminal. So let's go over those 5. Olfactory is smell. Makes sense from your brain to your smell. Okay, it can smell things. It's sensing. Optic is vision. That's sensing. Now we have oculomotor. That makes sense. Eye motor, movement. It's eye movement and pupil constriction. Trochlear, again, it's eye movement again. Trigeminal, this is your face sensation and chewing. It's chewing and you're feeling from your teeth, right? It's going to be both sensory and motor. Abducens, that's eye movement. Again, that's motor. So we got quite a few just for our eyes, don't we? Now you know why doctors are saying look to the left and right, look up. They're checking your cranial nerves to make sure they're working properly. Facial, that's cranial nerve 7. You do need to know that. Expect a question about cranial nerve 7 because they want you to know, oh, someone has Bell palsy or, their face is numb. What cranial nerve is that? That's cranial nerve 7. Vestibulotrochlear, that is going to be hearing and balance for your ear. Right, sorry, that's 8, not 7. 9, glossopharyngeal, that's going to be your throat, right? Your tongue and your throat. Taste, swallowing, and parotid salivation. Your vagus means your wandering nerve, like a vagabond. It's a wandering nerve. It goes all over. So that's going to be your speech, your gag reflex, your stomach makes you feel sick. Accessory nerve, that's 11. It's going to be your shoulder movement and neck. And hypoglossal, like lower tongue. Know it. So how can you remember this? You have to remember O, to touch and feel very green vegetables. That's how you remember it, right? Olfactory, optic, oculomotor. That's the way you can do it. And remember, if there is sensory, motor, or both, you can say, some say marry money, or some say money matters, but my brother says big brains matter more. An easy thing for you to write out, along with the numbers 1, 2, 3, 4, through 12, even if you haven't do it on the computer section, because when I wrote it, at least, they had a place you could write notes on the computer. So you'd be able to do this and help you remember, cranial nerves 1, 2, 3, 4, 5, all the way to 12. Then put, some say marry money, but my brother says big brains matter more. It'll help you remember all these things. So cranial nerve 5 is the star of dentistry. It's what matters the most for us because it's all the muscles of mastication are innervated by cranial nerve 5, division 3. And the anterior 2/3 of the tongue are also innervated by it. Trigeminal means 3 twins. Gemini is twin. So we have 3 divisions. The ophthalmic division, so your vision up there, eye, even though it's not moving the eye, it's the sensory. We have 3 divisions of the trigeminal nerve. Ophthalmic division innervates the forehead, the upper eyelid, the cornea, tip of the nose. So that's up here. Remember, it's not moving the eye. That's a different cranial nerve. This is just the muscles and skin around there. The maxillary division is sensory only. It innervates the midface, lower eyelid, right? Remember, these things are sensing. They're not moving the muscles. The muscles of the face are all cranial nerve 7. This is just sensing the touch or pressure or pain from that area. The mandibular division innervates the lower face, the lower lip, the chin, mandibular teeth, the floor of the mouth, the anterior 2/3 of the tongue, muscles of mastication, and it goes through the foramen ovale. Whereas division 2, access to foramen rotundum. We went over that already. Remember, cranial nerve 5, division 3, is the only one with motor function and sensory. Divisions 1 and 2 are only sensory. So here is a little chart. You can write out how it's relevant for dentistry and dental. Write this out. Cranial nerve 5 is the most important because it's sensory and motor. Facial is just facial expression for muscles and the anterior 2/3 of the tongue, and it stimulates salivary glands. Glossopharyngeal is the back 1/3 of the tongue. Stylopharyngeus stimulates the parotid gland. Vagus nerve is with swallowing, the gag reflex, and the soft palate. And 12 controls tongue movement. Here you go. Here you can see the 3 little divisions there. So that's division 1 up here. then 2, right, goes to your maxillary teeth, and then division 3 is going to your mandibular teeth. Here's another little branch. You can see that trigeminal nerve 5-1, 5-2, and 5-3 at the bottom. Notice that the tongue is by division 3, not the maxillary branch. So key tips, 7 is involved in Bell palsy, dry mouth, and facial expressions. 9 and 10 are relevant in the gag reflex and swallowing. And 12 is tongue movement. So if we have damage to that, we could have difficulty moving our tongue and swallowing. For injection relevance, focus on the mandibular foramen. If you're alveolar nerve block, we need to, the mandibular foramen is way back there in the ramus of the mandible. That's where they're freezing back for the IA block. The mental foramen, that's going to be for your incisive block, right? Or your mental block, right by there by your mandibular foramen. The incisive foramen, that's going to be for your nasopalatine block. Freeze right there. And your GP, that's going to be for your GP block. And for your infraorbital, that's going to be your ASA and MSA block. Now let's go over the muscles of mastication, the muscles of chewing. They're very important. Please know these in the most detail. What's the origin and insertion, and what do they do? I wouldn't bother memorizing all of the origin and insertion for other muscles, but for muscles of mastication, I would. Temporalis, that's here. That's what you feel when you squeeze. When you clench, you can feel the temporalis muscle. La is your lateral pterygoid. It's what opens the mouth. Medial pterygoid, again, this involves in closing the mouth on the inside or the medial side of the mandible. Here's a picture here. You can see the medial pterygoids on the inside where it inserts. There's the masseter, the biggest muscle of mastication there on the outside. When you clench, you can feel it. It's the main one for chewing. So 4 primary muscles. Write out the origin insertion. They're all cranial nerve 5, division 3. They all get their blood supply from the maxillary artery. That makes it simple. Just know the origin insertion and what they do. Right? Masseter elevates the mandible. Temporalis elevates and retracts, pulls the mandible back. Medial, again, elevates and assists in protrusion and pushing it forward. And the lateral, right? It protrudes the mandible, it depresses the mandible or opens, and side-to-side movements. So please don't get confused about opening, lowers, depresses. These words are used interchangeably. You need to be familiar with all of them. Here's a summary chart of jaw movements and how it works together. Which muscles are involved in elevation? Which muscles are involved in depression? Which muscles are involved in protrusion? Which ones in retrusion, bringing it back, or retraction? Know this. Know the different muscles that are involved in each one. And how I remember this is me, like to say the word me, my teeth are together pretty much, is medial. Your jaw moves up to say me. But la, your jaw has to drop. So that's la for lateral, to depress the mandible. Remember, only one muscle opens. That's the lateral pterygoid. Masseter and medial pterygoid form the mandibular sling. If you have cranial nerve 5, division 3 damage, you're going to have difficulty chewing. Jaw deviation toward the injured side, because it's not really pulling. And palpation, masseter is on top of the mandible. It's on the outside. And the temporalis is extraoral on the temporal during clenching. You can feel those. You can't feel the medial or lateral pterygoid muscles. You can't feel them. You can't palpate them. Muscles of facial expression. Skin movers. This is what makes you smile, squint, put your eyebrows together, raise a weird face. We have a lot of them. All cranial nerve 7. I would memorize all of these. I wouldn't bother memorizing origin and insertion, but you do know the cranial nerve is 7. I'm not going to memorize the arteries, but I would know which muscle can raise my forehead, make my eyebrows go up. That's going to be the frontalis muscle. Which one makes me smile? Well, that's going to be your zygomaticus, major and minor. Which one's an accessory muscle to chewing? It's not officially a muscle of mastication, but we call it an accessory muscle of mastication. That's the buccinator or the cheek muscle, because it's so helpful in chewing. Which ones can actually make you frown? What is that? Well, that's going to be your depressor anguli oris, right? Or your orbicularis oris isn't attached to any bone. It's just muscles are attached to it. right? Know these. Draw this out yourself. I'm sure you have anatomy and physiology textbooks. You got these pictures. I'm just telling you what you need to know. You need to know these. I have lots of questions online to quiz you on what muscle moves this and what do you think it is, so you can just feel more confident and ready for the board exam. Okay? You know it. Around the eyes, orbicularis aris closes the eyes, blinking tightly. The corrugator supercilii draw the eyebrows together and frowning. That's the corrugator. Frontalis is part of the occipitofrontalis muscle. It raises eyebrows and wrinkles your forehead. Right? And platysma muscle, that's when you do this with your neck. Yikes, that's bad. You see the muscles in your neck tense? That's your platysma muscle. Facial expression board exam tips. Cranial nerve 7 damage. You get facial paralysis on one side. That's Bell's palsy. Bell's palsy. Unlike muscles of mastication, these do not move the jaw. They just move the skin and facial expression. The buccinator is technically a muscle of facial expression, but it functions, or it's as an accessory muscle of mastication. That's it. That's Orofacial Anatomy Part 1. I have more of these for you. Good luck on your board exam. Remember to do the quiz. If you're getting 80%, move on. See you in the next one. Bye.